So thank you. And this completes the first part of our CTR. And what I'd like to do now is I would like to turn the podium over to Dr. Omar Khan, my fellow co-chair, who will introduce our keynote speaker.
Good morning, everyone, and thank you so much, Dr. Pachter, for kicking us off here, and really welcome to everyone and our fellow attendees. I just wanted to, first of all, thank everyone for being here today. My name is Omar Khan. I'm the President and CEO of the Delaware Health Sciences Alliance, and have the privilege of co-chairing today's conference with Dr. Marlene Saunders and Dr. Lee Pachter. I again want to extend our collective thanks to our organizational and administrative team, Deborah Reese, Karen Huff, Suzanne Profield, Keegan Connell, and many others, and our AV team, including George Watson and his team. I want to acknowledge the fact that we have not just so many attendees, we have over 300 folks registered, but they are from our partner institutions from many places around ACCEL and beyond. Certainly those representing ACCEL institutions in Delaware, in South Carolina, and other locations. We also have colleagues attending from other CTRs and other locations, such as from Puerto Rico, and we welcome everyone here today. The ACCEL leadership is a source of enduring support for all of the work that we do, whether in community engagement or community engaged research and beyond. And Dr. Greg Hicks, who leads from the front, welcome to your new role as PI. And I want to thank our other leadership as well, including Dr. Heather Bittner-Fagan, Dr. Mia Pappas, all our institutional leads, and the chairs of our advisory committees, who are extremely important in keeping us on track. The chair of our external advisory committee, Dr. Scott Wallman, for our internal advisory committee, Dr. Vicky Fananich, our community advisory committee, Dr. Marlene Saunders, and everyone who supports us. And certainly last but not least, our partnerships with our state colleagues is critical and extremely important. And as always, Lieutenant Governor Bethany Hall Long, your support is greatly appreciated. The Lieutenant Governor has been with us at every conference for ACCEL that we've had so far over the last 8 years. And as a healthcare professional herself and a professor at the University of Delaware, we greatly appreciate, Lieutenant Governor, all your support and all you do for us in the state of Delaware. Today's conference, as you heard from Dr. Pachter and from the presenters so far, is focusing on the critical issue of COVID-19 and the community. Our keynote speaker, Dr. Dan Salmon, is no stranger to this area, as he has studied vaccine hesitancy and issues around that for most of his career. Dr. Salmon is a professor at the Johns Hopkins Bloomberg School of Hygiene and Public Health. He is also the director of the Johns Hopkins Institute for Vaccine Safety. He received his PhD from the Johns Hopkins School of Public Health and his master's degree, his MPH, from the Emory Rollins School of Public Health. He has been at Johns Hopkins for many years. He's a faculty member in several departments there as a full professor. Incidentally, his predecessor, Dr. Neil Halsey, who I believe founded the Institute, was one of my mentors when I was a graduate student at Hopkins several years ago. Dr. Salmon's work focuses on the risks of vaccine refusal and of effectively communicating vaccine risk. And especially in the era of COVID-19 vaccine, where we're all well versed in what type of vaccines are given, whether it's the Pfizer or the Moderna or the AstraZeneca, it's important to have this robust conversation and also to engage with our community and with our researchers around what issues that might entail for the future. So Dr. Salmon's talk is going to address some of those issues today. And please join me in extending a very warm virtual ACCEL welcome to my friend and colleague, Dr. Dan Salmon. Dan, I'm going to turn it over to you.
Well, thank you, Dr. Khan. It's a pleasure to present to your group. And I appreciate the invitation from you and the other organizers. So I'm going to talk today about vaccine refusal in the time of COVID-19, looking at both opportunities, but also risks for community engagement and research. Moving on to the next slide. So I think that this is my big message. With crisis can come opportunity. It doesn't mean there will be opportunity, but the opportunity window is there. And if we think about COVID-19, it's caused global morbidity, mortality, and tremendous social and economic interruptions. And with that, we have seemingly very safe and very effective vaccines. And this is really an opportunity to demonstrate the value of science the value of vaccines, and of public health to control a pandemic. So with this crisis comes this opportunity. Next slide. So if we think about Operation Warp Speed, their primary purpose is ensuring that every American who wants a vaccine can receive one, and to make this beginning in January 2021. And this is their stated primary purpose. Next slide. And as of February this year, we have 2 vaccines that are available through emergency use. They've gone through large randomized controlled trials, 40,000 plus persons, requiring 2 doses and more than 90% efficacious, which is really remarkable. They both have very good safety profiles. There are fairly common adverse reactions in the first day or two: fever, achiness, tiredness, but they resolve within a day or two, more common after the second dose. And there's been no serious adverse reactions associated with the vaccines. Anaphylaxis seems to be a bit more common than other vaccines. Typically, we see a rate of about 1 in a million. With these vaccines, maybe it's 4 in a million. Those numbers are still being looked at, but it can be addressed and treated, and hasn't caused any death. We see other vaccines likely to come out soon, with the Janssen vaccine being discussed at the FDA's VRBPAC meeting at the end of the month. So this is really quite remarkable. I mean, we're less than a year in since the Operation Warp Speed program started, barely more than a year since the part of the pandemic, and we're already seeing very, very powerful tools for prevention. Next slide. So what will success look like? I mean, it's estimated that we need 70+% population immunity to effectively control the pandemic, and it may well be higher. And these estimates are based on assumptions of homogeneous uptake. And we know that's often not the case. We see with measles, with pertussis, with other diseases, that there's a geographical and social clustering of unimmune or unvaccinated people that can undermine community immunity. I mean, I think measles is the best example. Before the pandemic started, the World Health Organization declared vaccine hesitancy a top 10 global health threat. And in the US, we saw for decades pockets of unimmunized people, vaccine refusers, social pockets, geographical pockets. And in fact, in 2019, we almost lost our measles elimination status. So this is very hard to achieve. And for now, at least, we can't vaccinate children under 16 years of age. And if you do the math, that means we need 90% vaccine coverage among the rest of the population, homogeneous coverage. And it may get even harder, because with emerging strains, we might see a disease that's transmitted more easily, or vaccines that aren't effective. And the science is still being done in this area, so it's hard to know for sure. But the bar for success here is quite high. Next slide. So what are the challenges? I mean, the premise of Operation Warp Speed is, if we build it, they'll come, right? The stated goal is to make vaccine available to everyone. And simply having a vaccine doesn't accomplish our goals of disease control, right? If everybody has access, but we don't have high vaccine uptake, we're simply not going to control the pandemic. And we see real variability in perceptions of disease burden. There's a substantial portion of the population that thinks that COVID's not a serious disease, it's been overblown, that clinicians are over-reporting and ascribing mortality to COVID for financial reasons. And without recognizing the true burden of disease, it's hard to be motivated to vaccinate. These are new vaccine technologies, though they were in the work for a long time. They are certainly new vaccines. We don't have other vaccines to prevent coronaviruses. There's widespread distrust of the pharmaceutical industrial complex, and this certainly applies or creates the context for COVID vaccines, and the perception that the vaccines were rushed. And you put this together, and there's a lot of potential problems. And all of this has to be thought about in the larger context, where people have watched politics impacting science and response. And it's really undermined our credibility in our response to COVID more broadly. And this certainly carries over to vaccines. And then lastly, and I'm going to talk more about this, the potential for real or more likely coincidental adverse events to derail the immunization program. And we'll talk more about that. Moving on to the next slide. So these are some data that was put together by Dr. Oliver at CDC and shared with the ACIP. And it looks at vaccine intentions by survey month over time. And, there's a lot of different surveys that are being done looking at vaccine intent. They're on the right-hand side of the screen. And this is an effort to bring it together over time. And what you see that intent dropped probably to a low in September or October and then started to rebound. However, I would be a little bit cautious with these data because the survey mechanisms are highly variable. They're panel surveys. Some panels are much better than other panels. And in fact, the way the questions were asked were quite differently. So I think this gives a snapshot. It gives you an idea of what the trends look like over time. I just wouldn't read into it too much. Moving to the next slide. So I'm going to present some data from an ongoing project we have, understanding diverse communities and supporting equitable informed vaccine decision making. This is funded by primarily the Robert Wood Johnson Foundation and then supplemented by the Horizon Foundation. And it's a collaboration between the National Association of County and City Health Officials, which co-leads the program, the National Indian Health Board, ASTO, which is the Association of State and Territorial Health Officers, and then AIM, the Association of Immunization Managers. So this is a project that brings together local, state, territorial, and tribal immunization programs and health departments. Next slide. This is a list of contributors. It's a long list. I really want to emphasize the implementation partners that I just mentioned, as well as local facilitators of and from the communities in these different communities that have participated. Next slide. So the project goal is to generate information that'll be used by state, tribal, local, and territorial health departments in collaboration with community stakeholders to meet the needs of the population. And our goal here is informed decision-making and equitable uptake. So I would emphasize two things. Firstly, this is not a research project. This is a project which is really aimed at helping public health on the ground to meet the needs of the community. And then secondly, our goal is informed decision-making. This is not a project intended to get vaccine uptake or improve acceptance, though they're clearly related. Our goal here is to get actionable information for local public health. Next slide. So this provides just a high-level overview of the project methods and timeline. And we have wave one, which I'll get into in more detail, that started November 1st. It included a panel survey, online community conversations, and then rapid dissemination of findings to local public health. Wave two, which we're now into, which is mid-January into February, with more online conversations. And these are longitudinal. So we set up community meetings in the first wave, and we're continuing to meet with these same people over time. And it's because things are changing so quickly on the ground, and it affords us the opportunity to understand how people view the vaccine and the disease and how that evolves. And then lastly, phase three will be another survey and more community meetings, again, with the same community members. So I'm going to get into all of this with a bit more depth if we can move to the next slide. So this provides kind of a timeline and some benchmarks to think about it. So November 20th was when the first submission for an EUA was made to the FDA. And just a few days later is when our Ipsos survey started. And this is a panel survey, which I can talk more about. And that went on for a couple of weeks. So at this point, there were press releases about very high efficacy and a submission for an EUA, but no one had yet seen the data. As we moved into our wave one meetings, there was a submission of an EUA from Moderna over time, and just really emphasizes how fast things have moved on the ground. We saw the Pfizer EUA approved, And shortly thereafter, the Moderna vaccine received an emergency use authorization. So you really kind of get a sense of how these different waves and surveys were weaved into a really quickly evolving time. The only other thing I would point out on this slide, and it continues to show where wave 2 fits in and where wave 3 will fit in. But we really rapidly turned these results around for local, state, territorial, and tribal public health. So the wave 1 meetings ended the 15th of December, the panel survey a week earlier, and within a week we had all of these data analyzed and implementation considerations for local public health. So this is unusual in at least for an academic institution, and I think for anything that people think of as research, because our goal here is not discovering new information. Our goal is to inform local public health so they can take actions to meet the community needs. And this just requires things being really, really rapid. Moving on to the next slide. So the Wave 1 survey, the goal was to conduct a national survey to better understand interests, preferences, and factors that influence vaccine decision-making. This is using the Ipsos knowledge base panel. So there are a lot of panels out there, and the quality of those panels or the validity, especially external validity, is highly variable. And Ipsos is really one of the better, if not one of the best surveys panels to use. The survey was conducted between the 25th of November and the 7th of December, English and Spanish, and we oversampled Black and Hispanics and then adjusted for them analytically in our analysis. Next slide. So survey topics, there were a broad range of survey topics. We looked at primarily COVID-19 vaccine intent, but a broad range of other factors that would help us understand that better. Personal impact of COVID-19, confidence in the ability to avoid COVID, confidence in vaccine safety broadly, not specific to COVID, support for a communitarianism worldview versus individualism, and egalitarianism versus a hierarchy approach. We measured trust in local and state public health and trust in CDC. And for these constructs, we used well-developed and validated scales. We looked at other attitudes such as severity of COVID, mask wearing, the value of therapeutics, other factors around COVID-19 vaccines such as effectiveness, safety, the value or importance of the vaccine for controlling outbreaks, and the requirement for personal information to be provided in order to get vaccinated. And then we had broad demographics available on the panel. So we didn't actually have to ask them of participants. This was information that was already collected: gender, age, education, region, income, and political affiliation. Next slide. For the first round of public engagement, our goal was to foster conversations about COVID-19 vaccine and perspectives to understand why people see them as they do. And, this is the beauty of community conversations and a richness that it's hard to get in surveys, and you can really get into the whys, and you can understand how people are making trade-offs among values and decisions as they think through processes. We had 25 online conversations that were both regional and local. So we targeted Native American, African American, and Latinx populations. These were the local populations. And then using people from the Ipsos panel, we had regional meetings, 2 groups from each of the 4 regions. And these were among people that were largely vaccine hesitant. They were held the first 2 weeks in December. They varied from 90 to 180 minutes. The Native American meetings were longer, and there was a lot of storytelling, which is common among that population. We had 4 senior facilitators that teamed with 7 local facilitators that were people of and from their communities. We used a standardized meeting approach, but we really customized it to meet the needs of local communities. And these were conducted in both English and Spanish. Next slide. So in terms of the core question, we wanted to know what information would be helpful to them as they think about and consider COVID-19 vaccines. what were some of the practical barriers they might face, and specifically, what advice would they give to their local health departments? Because, you know, that's what this was really about, was how can local health departments learn from their communities? We asked about confusing and conflicting information, because we knew there was a lot out there, both in terms of the vaccines, but also other COVID-19 control issues like mask wearing. And how do they make decisions about vaccines in that context? And then lastly, you know, there's a lot of reasons why people may choose to get vaccinated or not, and to try to understand how people thought through those different benefits around vaccination. Next slide. So the Wave 1 survey findings, we found there were three groups of people which we categorized as intenders, wait and learn, and unlikelies. So intenders, which was exactly half of the population overall, but we'll talk about those subtleties, were people that definitely or probably wanted to get the vaccine as soon as possible. So these were people that were ready to go. If we build it and make it accessible to them, they are ready to stand in line. And then we have the wait and learn group, and this was 40% of the population. And those were people that were, you know, probably going to get the vaccine, but not right away, or those who would probably not get the vaccine, but they really had it made up their mind. And then lastly, the unlikelies, 10% of the population that intended, you know, this is intent, right? It hasn't been offered to them, but they did not intend to get the vaccine. And we're going to get into each of these groups in a bit more detail. Next slide. So let's talk about the intenders first, right? This is 61% of the population over 60, about a third of Blacks, the majority of people, 63%, with a bachelor's degree or more education. They were more likely to be Democrats than Republicans or independents, more likely to support communitarianism worldview than individualism, and egalitarianism versus hierarchy, and to have more trust in health departments and CDC. They were much more likely to be confident in vaccine safety broadly. Next slide. So I'm going to provide, as I go through these data, odds ratios. And for these different scales, we dichotomized them and then produced an odds ratio. Now, these are not rare outcomes, so I would not interpret them in terms of a relative risk, but they do show a strength of the association, right? So an odds ratio above 1 would show that there's a positive correlation. Between 1 and 0, they can't be less than 0, would be a negative correlation. And the higher the odds ratio, the higher of magnitude. And that's really why I'm providing the odds ratio. So for example, if you look at consider a COVID-19 vaccine important, you see an odds ratio of 44. So that's a really strong association. But I just want to provide a bit of caution in interpreting these. So compared to the rest of the population, we saw that intenders were more likely to be in a metro than a non-metro statistical area, more likely to have a high income than a low income, more likely to be diagnosed with a high risk condition for COVID-19, much more likely to have received a flu shot in the past year, to have discussed COVID-19 with their healthcare provider, to perceive COVID-19 as severe, much more likely to see the value of vaccines to control the pandemic, and more likely to wear a mask, usually or most of the time. Of course, this is self-reported mask wearing. The next slide. So the wait and learn group, and this I think in many ways is the most important group for us to focus on. While the majority of the elderly reported that they intended to get the vaccine, we still saw a third that were in this wait and learn group and they were unsure. And this was disproportionately Blacks. About half of the Black community were in the wait and learn group. They were more likely to be in good or fair health, to have known someone with a previous severe or serious vaccine reaction, to be worried about government requiring personal information to get a COVID-19 vaccine, and to be concerned that the government and drug companies experiment on people like me. Next slide. We also found that compared to intenders, the wait and learn group were less likely to be in a metro than non-metro statistical area, to report high income versus low, to be Democrat versus Republican, to be diagnosed with a high risk condition, much less likely to have received flu vaccine, to discuss COVID with their healthcare provider or perceive COVID as severe. And if you look at the odds ratio here, far less likely to consider COVID-19 vaccine important to stop the spread of infection, and about half as likely to wear a mask usually or most of the time. Next slide. Compared to intenders, they were less likely to support communitarianism and egalitarianism and to have trust in health departments and CDC. And they were much, much less likely to be confident in vaccine safety. So, this is, when I say confident in vaccine safety, it's not specific to COVID vaccine. This was a vaccine confidence scale. And we see that, people who were worried about the safety of vaccines, this does in fact carry over to COVID-19 vaccines. Next slide. And lastly, looking at the unlikelies. While it was 10% of the population overall, it was 15% of Blacks, 14% of people with a high school education or less. Compared to intenders, unlikelies were less likely to be elderly, to have a bachelor's degree or more education, to have a high income versus low income. They were less likely to be Democrat versus Republican, less likely to see themselves as likely to be infected with COVID, and far less likely to discuss COVID with their healthcare providers. Next slide. Other differences we see with the unlikelies, and this is again comparing them to the intenders. They were less likely to perceive COVID as severe, to consider the vaccine as an important to stop the spread of infection. I mean, it's a tiny odds ratio there. They were far less likely to have received flu vaccine, to discuss COVID-19 with their provider, to self-report wearing a mask. And, we also see, again, very small odds ratios for communitarianism and egalitarianism, much less trust in health departments and CDC, and far less likely to be confident in vaccine safety. Next slide. So what are the key emerging issues from the community conversations? And I'll go through these broadly. Remember, these are conversations, so I'm not able to provide to you, p-values, and we're careful not to over quantify these findings. Though we did do a little bit of polling I'll share with you, but the vast majority of participants were still forming their views and they want more information. So this group that we call Wait and Learn, they really are learning. They're not people that have made up their mind, and that's really the good news. We heard a lot of concern about the vulnerability of family members, and this was often an important factor for people's decision making. And for some minority groups, especially the Latina and the Native American, they were really interested in protecting the community and vulnerable portions of their populations. There were broad concerns about vaccine safety, and we really heard that numbers matter. And when I say numbers, I mean a lot of people really wanted to see a lot of other people vaccinated first. And we heard things like, well, I want to wait until, millions of people have been vaccinated before I make up my mind. We heard a lot about lack of trust in government and pharma. And in many of these conversations, the history of exploitation of their communities just quickly became front and center. And it's really in this context that many people are seeing this pandemic and these vaccines. We heard wide variability about sources of information that were trusted. Some people immediately turning to Dr. Fauci, yet other people returning to elders in their community or religious leaders. So there was very wide variability in where people wanted to get their information. And much of this was in the context of changing or conflicting information. So people talked about, well, I hear this and then I hear that about the pandemic and about what I'm supposed to do. And it makes me not really sure because I'm not hearing consistent messaging. Next slide. Other key issues that emerged, there was a lot of variability in perceptions of the risk of disease. We had some communities like our New Orleans African-American group, Native American populations, where the community had really been devastated by COVID, and people knew personally people who had died and had really been impacted. And there were other persons where, you know, they saw it on TV, they knew a couple people who might have gotten sick, but the impact on the community was really quite different. We saw really different views of individualism versus communitarianism. And especially in the Latinx community, you know, the communitarianism really came out strongly. And it was really quite variable. We saw a broad desire to get back to normal. And, you know, that was a term that people just kept using is, you know, we want to get back to normal, whatever that new normal might be. Many people raised concerns about cost and the vaccine being mandatory. And this was interesting because this was one of the things or two of the things that popped out when we first raised the issue. So before we really had any deep conversations, we said, well, what do you think about COVID-19 vaccines? And people immediately started bringing up, well, I'm not sure we'll be able to afford it. And I'm afraid they're going to make it mandatory. And it was in this context that many people perceived the vaccine and thought about the vaccine. And I think that's really important because, in fact, at this point, cost is not a barrier, at least for the vaccine and vaccine administration. And it's not being made mandatory. So I think that addressing those barriers early is important. And we really saw a desire from community members to have safe forums, to listen, to deliberate, to ask questions. And, you know, we have a lot of experience holding these sorts of community meetings. Doing it online is a new thing. And we were worried about how engaged people might be. And I think we've all spent a lot of time sitting on meetings and struggled with really staying engaged. And it was remarkable how much people really wanted to have these conversations. Next slide. So moving on to the second wave, and I'm just showing here our retention levels. So these were the different meetings. How many people were in wave one? We had almost 400. And moving into wave two, we had almost 90% retention. So these people really did stay in these groups. Next slide. Coming out of our wave two community meetings, and these are really hot off the press. I mean, this just finished up over the weekend. So these are preliminary findings, but, you know, we put together this figure on the left, and we, you know, kind of saw fully considered COVID-19 vaccine decision-making. This is our goal in the middle. In four pieces. One is to provide information about the vaccines, and there's clearly a need for information, but at the same time to clarify and align these with people's values and lived experiences. They're not looking at the vaccine in isolation. To support the process of decision making and to make it easy, lastly, for public health and immunization partners for those that want the vaccine. We saw a lot of increased comfort about the vaccine among many people, and I'll show you some data. And the perspectives varied by community and how people perceived it, and the changes varied by community. Safety concerns persisted, and the information needs were evolving, and they continued to evolve. Next slide. So these are polling data from these meetings, right? So this is not from the Ipsos survey. These are not nationally representative. These are polls that we conducted among these community meetings. And it's a little bit complicated, but I think it's really interesting. So let me walk you through this. We have the different options of vaccine intent. Definitely get it as soon as I can, probably get it as soon as I can, probably get it, but not right away, probably not get it, definitely not get it. And then in the second wave, some people that actually received the vaccine. And then we break it down by community: Native American in yellow, African American in red, Latinx in blue, and then the regional meetings in green. And with the stripes is the difference between the first meeting and the second meeting. So if we start to the right of the slide, we see that, you know, some people have already received the vaccine, which is great. And it's actually differential by community. I mean, the Native American and African Americans had self-reported higher uptake. But among the rest of the groups, we see people are kind of moving along the continuum. So even if you take the group that said they definitely would not get the vaccine, among Native Americans and African Americans, among all groups, there's far less. So people have, even starting off in that seemingly strong position, have really diminished. And as we get along the spectrum from right to left, we see a lot more among many of the groups that were more likely to get the vaccine. So, for example, probably get it as soon as I can. Among Native Americans, that really increased. Among African Americans, that increased. Um, a little bit among the Latinx, but even in the regional meetings, which were people that were identified as being vaccine hesitant. So, this is encouraging. It's imperfect, it's not generalizable, but it shows a real movement towards vaccine intent. Next slide. So other preliminary findings, and again, these are very preliminary. These meetings just ended this week. We saw concern about the speed of vaccine development continued to be an issue, but had decreased. Experience with the vaccine rollout had been very uneven, and we heard very different experiences from different communities. There's still a wait and learn perspective for many people, though people are moving along the spectrum. There was support for decision making to be customized for each community. And it was just so abundantly clear that the perspectives of these communities were very different. And even among those people who didn't want the vaccine now or ever, they were interested in what else they could do to try to support ending the pandemic. And to us, the take-home message was meeting the moment, because we're really in that moment. Moving into the next slide. So take-home messages from this work. Currently, demand is greater than supply. And for those people who want the vaccine, we need to make it easily available for them. We need to ensure access for those that are experiencing health disparities. And we see clearly the potential for these health disparities to be furthered by the vaccine if we're not careful in how we roll it out. So while the vaccine has the potential to help overcome these health disparities, it's going to be very easy for the vaccine program to fall into the trap of other health programs that disproportionately benefit those with resources. We see a substantial proportion of the public still have not made up their minds. And we have to understand this is reasonable. I mean, these are vaccines that are under emergency use authorization. They're not yet licensed through a BLA. And people are trying to understand the different aspects of the disease and the vaccine. And this is really an opportunity to support their informed decision making. And public health needs to build trust now by being a partner. So for this first group, the half, and my guess is the half has probably increased a bit, it's all about access. We build it, they will come, and that will help. But they're not going to get us all the way there to control the pandemic. And this larger group of wait and learn are going to be much harder to work with. And we need to start doing that now so that when the vaccine is available to them, they understand the risks and benefits and make an informed decision. Next slide. So, I'd like to bring up two areas where I think that we're vulnerable. And one of those is the perceptions that politics is driving science. And secondly, the potential for a vaccine safety scare to undermine public confidence. Next slide. So if we look at the issue of politics driving science, and I think we've all seen this from the beginning of the pandemic, here's a quote from former President Trump downplaying the pandemic, saying that it's going to disappear, and it's disappearing, just as there was a major surge starting and predicted broadly among the public health community, and even an acknowledgement that this approach was intentional. So certainly from the White House, we saw this, but the FDA was also scrutinized in some of the early EUA decisions. And perhaps most importantly, this is what the CDC does. And we have probably the best CDC public health response in the world. I mean, there's such a rich and long history here. This is what CDC was made for. And normally they would lead efforts around pandemic response and related communications, but at least up until recently, they've been largely sidelined. And I think it really provided the perception to the public that it was politics driving science. And this is really problematic. Moving on to the next slide. You know, I'm showing a figure here from one of my all-time favorite papers. This was written by Jeff Copeland when he retired as CDC director and went to Emory University. And he talks about how in scenario A, science drives public health, it drives policy, it's left to right. And he gives lots of examples from immunization programs that this works well. And then he contrasts that with scenario B, moving right to left, where politics drives public health, that drives science. And he gives examples of that, like our early response to HIV. And the point he makes is we need to stay in lane A. As long as we're in lane A, we make good decisions. And public health is a very variable, very powerful tool. But when we slide into scenario B, this is when bad decisions are made. This is when decisions aren't consistent with the science, and the science doesn't even reflect reality necessarily. And we lose public confidence in the ability to make good decisions that are credible. So I think this is just an incredibly timeless paper, because this is so true for public health and science, and so timely and relevant to where we are now. Next slide. So I just have a few more minutes, and I want to raise a few more issues. Firstly, on an optimistic note, with the new administration, we have opportunity. CDC can assert their expertise and demonstrate to the country their value. President Biden strongly stated that he will follow the science. The resources are required for the feds, for states and localities. And we're starting to see CDC rather than politicians providing information. And that all gives me reason to be optimistic. At the same time, the political polarization of the country remains a challenge. Next slide. So I'd also just like to raise one other issue as under a risk, and that is for a vaccine safety scare to derail a program. And real safety problems are always possible. I mean, it's unlikely, but it's possible. We have to acknowledge that. We have to understand the limitations of clinical trials, and I'll talk about that a bit more. So there's always the potential for a real safety problem, but it's really pretty unlikely. There's a far higher risk that there will be a coincidental relationship with vaccination. And look at it this way. Bad things happen to people every day, right? That is the background rate of every disease we study. And if you vaccinate a lot of people in a short amount of time, such as a mass vaccination program, there's a huge potential for a coincidental relationship to derail the program. We saw that in South Korea with their flu vaccine program last year, where there were a few deaths that were initially attributed to the vaccine. Further studies showed that, in fact, they weren't caused by the vaccine, but by that point, the vaccine program was toast. Moving on to the next slide. So, you know, vaccine safety science, there's an incredible importance to rigor here. And the approval process through RCTs ensures that the benefits are greater than the risk for the populations and the outcomes studied. But we need observational studies after that to examine uncommon events, to look at populations that were either excluded or inadequately powered in the studies, or delayed onset adverse events. And infrastructure, large healthcare databases really helps us do this quickly. Next slide. So this is a table I adapted from a paper Susan Ellenberg wrote, and it makes the point about size. So in the first column, we have rates, and this would be the background rate versus the new rate. So let's say if something happened, the background rate was 1 in 1,000, and you wanted to detect a difference, a doubling of that risk to 2 in 1,000, well, that would take a sample size of 50,000 persons. So it gives you a sense of the power of clinical trials. With that said, if you were to miss that, and you were to give everybody in the country 1 dose of the vaccine, or if the event only happened after the first dose or the second dose, you know, that could potentially impact 328,000 people. And if it were 2 doses, it would be double that. And, so this is about where our studies are powered, depending on the trial. But then as you get into things that are more rare, like from 0.05% to 0.1%, you would need a clinical trial with 100,000 people. And if you miss that, you could still impact a large number of people. So, it just gives you a sense of what is the power of RCTs and why we need to study vaccines post-licensure or post-authorization. Next slide. There's this fallacy, and this is the fallacy that I'm most afraid of when it comes to vaccine safety in this vaccine program, is that when one thing happens after the other, people presume causality. And it's a human fallacy. And this is exactly where we're most susceptible and most vulnerable. Next slide. This was a paper that we published right before the H1N1 2009 vaccine program. And we published this in the Lancet, and we looked at different outcomes like Guillain-Barré and optic neuritis and spontaneous abortions. We looked at different population and looked at the rates within 1 day, within 7 days, within 6 weeks. And the reason we got this out there before the vaccine got out there was we wanted to make people aware. We wanted to make the medical and public health community and the media, because we shared this broadly with the media. And the point here is as I've been trying to make, which is bad things happen to people every day. And if you vaccinate a lot of people, you can anticipate these things will happen within 1 day, within 7 days, within 6 weeks of vaccination. Next slide. So what do we need for COVID vaccine safety monitoring? We need to identify adverse events that are caused by the vaccine. If and when that happens, Guillain-Barré syndrome after the 76 swine flu is an example. We need to address spurious associations because bad things will happen every day. And we have to, most importantly, distinguish between the two. And we need to do it with rigor. We need to do it with speed, and we need to do it with credibility. Next slide. So I'm going to quickly go through a couple of examples of what worked and what didn't work. And I realize we're short on time, but a great example of what worked was the Qatar incident. The launch of the polio vaccine was accompanied with reports of paralysis following vaccination. CDC had just established the EIS to rapidly investigate outbreaks. And this was one of their first investigations. They quickly identified that there was a manufacturing problem with Qatar, primarily, though it was a couple other vaccines as well. The vaccine was halted for a very short amount of time, but because the response was rapid and robust and rigorous and objective and transparent, the program quickly resumed. And we're on the verge of polio eradication. One can only wonder where we would be with polio had it not been handled in this way. Next slide. Another example of what worked was H1N1 safety monitoring. I mean, this was the mass vaccination program in the midst of a crisis in confidence. And we think things are, bad now, but in 2009, people were really worried about vaccine safety and confidence in the vaccine. This program, the last time we rolled out a mass flu vaccine program was the 76 swine flu fiasco. We had the most comprehensive safety monitoring and communications program ever anywhere. And what that vaccine program is known for is not a vaccine safety crisis. Next slide. An example of what hasn't worked, we can look at autism. There's others. Next slide. So if we look at the autism issue, at this point, we have 16 methodologically sound controlled epi studies looking at a relationship between autism and MMR vaccine, thimerosal vaccines, simultaneous vaccination. This was done by different investigators in different countries using different methods. And all 16 of these find no relationship between the vaccines and autism. And some have said, well, what's the point of science? People don't believe this. Roughly 1 in 4 Americans still think vaccines cause autism. The science doesn't matter. And I think that's the wrong conclusion. Moving to the next slide. Here I've taken these same studies and I've put them on a timeline. And on the bottom is when the MMR hypothesis was first raised by Andrew Wakefield. And then when those studies came out, and we saw 18 months for the first study, a couple of years for US data. And in this time period, you had a charismatic, well-credentialed person traveling the world telling people they saw that he found a relationship between MMR vaccine and autism. And that time, that gap was just so problematic. The same thing with thimerosal and vaccines. Now there's been 6 studies, all negative. But look how long it took for these data to become available. And even more so with the hypothesis that multiple vaccines cause autism. I mean, it took years. So I think the science matters, but timeliness matters. Next slide. So, what is my point here? Good science takes time. Whereas anecdotes, sensationalism, and bad science travel quickly. And it's very hard to change someone's mind. What we really need is science that informs their view. Next slide. So I'll close with this. The moment is now. We have the opportunity for vaccines and public health to turn the tide on the pandemic. They could have a tremendous impact on COVID-19. They can demonstrate the value of vaccines, the power of public health, and the science and institutions that can make a difference. So, we need to get this right. We need to get this right for COVID, and we need to get this right for the future credibility and success of public health and science. So let me end there, and I'm happy to take questions. I think Dr. Khan was going to moderate this, and I appreciate him doing so.
Very good. Thank you so much, Dan. That was wonderful, extremely timely, and really appreciated your comments. We have a few minutes for questions. So I tried to answer a couple of questions in the chat box, which really around sharing your slides and the information. And as our administrative team shared earlier, the information will be made available to our attendees after the conference as well. So first of all, thank you very much. You emphasized some vaccine uptake strategy and principles, and that was really very helpful. I love the slide that you shared from Jeff Copeland around science, policy, public health, that continuum versus going the other way around. Would you have any ideas for how then do we change that narrative from being either A or B, rather than always having science lead to policy, lead to science lead to public health, lead to politics, or the other way around? Should science and politics not try to work together in concert from the beginning through community engagement in order to collectively influence public health? Have you seen good examples of where that might work?
No, I think that's what has to happen. I mean, there is a connection, but the question is, what is driving what? So I'll take an example. I was talking early in the pandemic with a former student that was in Seattle King County Health Department, a very strong health department. And she was describing the difference in how they've handled their initial COVID conversations publicly compared to, for example, New York. And in New York, we saw politicians out there discussing the issues, some better than others, I mean, in terms of facts. But the challenge is that by definition, politicians are polarized, right? Half of people are going to believe them. The question might be which half. Whereas in Seattle King County, they had their public health leaders out there, and the credibility can be and probably should be much higher. And so I think that there is a connection. It's a natural connection, and the way we do it is by doing it, and by not allowing politics to drive our message, but to have science drive the policy and the politics. And a lot of this is, I mean, it's basic training in an emergency. This is what we know. This is what we don't know. This is what we're doing to fill the gaps, and this is what you should do for now. I mean, we've had these approaches for a long time. We just need to follow them. And it's when we pretend we know more than we don't where we get into trouble.
Agreed. Thank you, Dan. Another series of questions pertains to essential workers, for example, physicians and frontline folks, and communities and patients that one might interact with. So a series of paired questions around that. One is, how do we confront hesitancy within the essential worker population itself? They could be any type of frontline worker. They could be teachers, they could be those fighting fires, they could be physicians, they could be nurses. That's one question. Has your research looked at hesitancy among those charged with perhaps care delivery? And the related question is, what might you say if you had one thing to say to a vaccine hesitant, vaccine concerned patient for legitimate reasons, as you pointed out, but they were in your office and you had 1 minute to drive a point home with them? How might you address that to the provider and to the patient in this case?
Yeah, so we have done some work um, around health systems, and I would refer to a study that a colleague, Yana Shaw, at University of Syracuse recently published in CID, and we did a survey of a very large healthcare system in New York, and we found among the physicians and scientists very high levels of vaccine intent, but as you got to nurses and PAs and less training, they looked more and more like the public. In fact, among the nursing population, they looked remarkably like the public in terms of the proportion and the concerns. And I think that's a really challenging population. One, because they've been prioritized for good reason. And if they're not vaccinated, that's a problem, more so than most people, which is why they're prioritized. But the message that sends to the public is really concerning. And I think other institutions have data like this, and people are afraid to make it public because if the public sees that their nurses are not ready to get vaccinated, it could really adversely impact them. I think how you deal with it, whether it be a nurse or a firefighter, is the same as it is with the public. I mean, if they're seeing things in similar ways, then just because of their occupation, it may not be all that much different, though you can emphasize why they're prioritized. I think a minute is a hard time to have this conversation. The first thing I do is I listen and I hear what people's concerns are. I then connect with them. And I find common ground and common value. I do it carefully. I don't want to reinforce a myth. So if somebody says, well, I'm worried about vaccine ingredients, I don't say, oh, well, I understand why you're worried about vaccine ingredients, because even if I then debunk the myth, I've reinforced it. But what I might say is, I understand why you want to make sure that everything goes in your body is safe. So I'm connecting with the value, and then I can address the issue. In under a minute, that's really hard to do.
Agreed. Thank you so much, Dan. That's really helpful. Uh, a couple of things which you mentioned around the nature of truth, the nature of information. I'm reminded of the old adage that a lie is halfway around the world before the truth even has its socks on. And that certainly is the case with vaccine misinformation, and on a global scale, whether with the Wakefield study or anything else faked that makes its way around the planet. Do you see the role of social media and other public communication mechanisms that have so far been underutilized in science in order to combat actual fake news? Do you see conventional scientific methods as being more effective in the long term? What do you think is the mix for COVID-19 vaccination hesitancy?
I think that we in public health have been slow to use new social media, and I think that it's often a cohort effect. I mean, I can tell you that as a child, I was one of the first people to get a home computer, an Apple II Plus. And now I turn to my kids when I can't get my computer to work, and, there's a strong correlation between age and comfort with technology. And I think that in public health, we've been hindered in our use of social and electronic media, and I think it hurts us. And I think we're just starting to wrap our minds around that and starting to come up with approaches that take advantage of social media. But it's a much harder venue um, to address these issues. And we quickly get beyond capacity. I mean, I've seen several initiatives where people want to combat misinformation on the internet. And, that is a Herculean task. The resources that it would take to do that are immense. So I think this is one of the real challenges we face in vaccine hesitancy and public health and science, and it's really coming to bear with COVID. I don't think there's a simple solution. I think it's a deep problem.
Very good. Thank you so much, Dan. We are almost at our time. I wonder if I might try to squeeze in one other question in keeping with my interest in global health as well. And Stephen Wolf asked this about the experience of many other countries, both in terms of initial COVID-19 response and in terms of now vaccination, has been that there has been significantly better uptake of prevention measures in several other countries, certainly in several Asian countries, perhaps not so much with some of our European colleagues, but certainly in terms of vaccination, we're seeing good uptake and perhaps lower concern and lower hesitancy. Does your work or your impressions, is that borne out as well, that countries where they were more compliant perhaps with COVID-19 prevention, they appear to be less hesitant with COVID-19 vaccines? And are there lessons to be learned from those settings for the United States as well?
I mean, I think it's a great hypothesis. I don't think we have enough data yet to answer that question. I mean, we're just starting to get vaccine rollout. So demand is so greater than supply that it's really hard to know. But I strongly suspect that that, in fact, will be the case. You know, there's been such a focus on individual rights here. I never imagined a world where wearing a mask would be so controversial and such an infringement upon individual autonomy. It's such a simple ask. I mean, a bit inconvenient. I still don't care for them myself, but in the midst of a pandemic, and look at how that's been polarized. So I think there's huge variability in country response, as you point out. It probably will be correlated with vaccine acceptance and refusal, and time will tell. I mean, you know, I can only say this: if there was going to be a natural disaster that was going to be handled so poorly, I really wish it would have been in somebody else's field. I mean, having been so directly involved in H1N1, where we had really strong leadership, was a very different situation. It's difficult to watch how this is being handled. And I really hope that now, with new leadership, that can change and we can pull it off.
Absolutely. Thank you so much, Dan. I'm encouraged by your comments and the fact that, yes, indeed, we have strong leadership. We have masks all over the place now. We have less hesitancy, and we have done pretty good work as a country in terms of getting vaccines at least developed, if not fully rolled out yet. So we have some positive spots. And of course, we have our community engagement efforts that folks like you inform us about and certainly help us along that pathway. So again, thank you so very much, Dr. Dan Salmon from the Johns Hopkins Institute for Vaccine Safety. Always glad to have you with us. Very much appreciated. For our audience and our attendees, thank you so much for your attention. We're going to take a short 10-minute break, after which you will be welcomed back here by co-chair Dr. Marlene Saunders for the next session. Please join me in virtually thanking Dr. Salmon, and please take a short break. We'll be back soon. Take care.
Thank you. Thank you.